The neurodevelopmental chapter of Indian Academy of Pediatrics has come up with a consensus statement on the habilitation process of neurodevelopmental disorders, which are seen in increasing numbers these days. But it is important to remember that the recommendations of these statements should be understood in close conjunction with consensus guidelines on the diagnosis and management of global developmental delay, which I had discussed in an earlier video and the link of which I have shared below. And the guidelines, the recommendations of this consensus statement I have summarized in this video along with explaining the salient features. What causes neurodevelopmental delay is any significant or persistent disruption in the dynamic interrelationship between genetic, brain, cognitive, emotional, and behavioral processes through environmental and biological risk in the F1000D. What is it? F1000D is the first 1000 days of life, that is 270 days of intrauterine period, 365 days of first year of postnatal life, and 365 days of the second year of postnatal life. So up to 2 years of age, it is very important because the development of brain primarily takes place in this phase only. So the likelihood of development of this neurodisability or neurodevelopmental disorders is maximum in this period, and any disruption can lead so. There are two terms, habilitation and rehabilitation. So actually there is a sequence of events. Impairment leads to disability, and disability ultimately leads to handicap if no intervention is done at any point of time. Habilitation is the process of learning to prevent impairment progressing to disability, and rehabilitation is a process of relearning to prevent the disability going on to handicap, which is almost a permanent kind of thing. Why is it important to understand? Because we will be using these terms repeatedly in this video. So there are 6 steps in habilitation which I have summarized here. First is a preventive management in conception, pregnancy and perinatal period, which is referred to as PCPP. This is followed by implementing best practices in the labor room and NICU to minimize brain injury once the baby is born. Then early stimulation after the baby is delivered via various means. Very early risk stratification in case the baby has been admitted in NICU. Early detection of the slightest or the slyest of disability, and early intervention, which involves giving an individualized care plan. This is referred to as the biopsychosocial model, and this involves allied specialists. So we will be dealing with each of these steps one by one and shall be simultaneously discussing the recommendations. Starting with preventive management in conception, pregnancy and perinatal period or PCPP. The risk factors for neurodevelopmental delay which can be present in mother are advanced maternal age, maternal antepartum bleeding, maternal prenatal medication use, non-pregnant maternal weight, maternal height, severe anemia, pregnancy-induced hypertension and maternal short stature. In newborns, it can be first order pregnancy, meconium aspiration, feeding difficulties, prematurity, low birth weight and socioeconomic status can also be a risk factor for neurodevelopmental delay in a newborn. But what is important to remember is that the single most important modifiable risk factor in the fetus is low birth weight. Modifiable antenatal factors for low birth weight babies include pre-pregnancy maternal weight and height, maternal nutrition and maternal infections primarily. Hence, the preparation for prevention has to be started much earlier, and this leads to the concept of preconception counseling. This is aimed to reduce the risk of adverse health effects to all, that is the baby, the neonate as well as the mother, by addressing modifiable risk factors even when the mother has not conceived the pregnancy. Babies at high risk are those born out of assisted conception, having some genetic predisposition like chromosomal aberrations, monogenic disorders, mothers having intrauterine infections, exposed to toxins, maternal malnutrition, maternal torch infections, or babies who have developed neonatal hypoglycemia, significant neonatal jaundice or bilirubin encephalopathy, and who belong to family with pathological functioning. So the tools which can be used for early detection in these babies are Hammersmith Neonatal Neurological Examination, Brazelton Neonatal Assessment Scale, Perinatal Risk Factor Stratification Tool, Pressure General Movement Assessment, and abnormal cranial ultrasound findings in the newborn period. These tools are basically helpful to screen newborn babies. HI staging, as you already know, is done by modified Levine or by Sarnath's staging. There are certain components of preconceptional care, and these involve additional nutrition to prepubertal girls, family life and life skill education for adolescents, immunization, especially rubella, hepatitis B, human papillomavirus during early adolescence, preconception folic acid intake, addressing body image, cosmetic concerns, and dental care of females, regular medical checkups, ultrasound scans of abdomen and breast if indicated during pregnancy, screening for menstrual problems, PCOD, genitourinary infections, screening for anxiety, depression, suicidal ideation. For newlywed couples, we need to counsel them about sexuality skills, understanding needs of self and partner, and self-counseling for developing coping skills. So the first recommendation primarily stresses on focusing on prepubertal girls' nutrition, family life education for adolescents, and premarital and newlywed counseling for above 18 years as a part of focusing on first 1000 days, that is F1000D. The epidemiology of the early stages of neurodevelopmental disorders, especially during F1000D, is not available in India. So the next recommendation is emphasizing on a need for nationwide studies with representative sample on epidemiology of babies with early neurodevelopmental disorders in the first 1000 days in India. The next step in the habilitation process is of implementing best practices in the labor room and NICU to minimize brain injury. This involves promoting efforts to organize systematic training programs in newborn resuscitation program, which is held at a massive scale, especially during postgraduate training. Lactation management, developmental follow-up, and early stimulation for SNCU and ICU graduates has to be stepped up more. This process actually involves training of NICU staff in resuscitation and essential neonatal care, provision of optimal perinatal care, optimal nutrition and developmentally supportive care practices, optimized intensive care practices, promoting readiness of healthcare facilities, supporting the family and quality initiatives, especially regards to NICU. The next step involves early stimulation. It actually refers to doing simple everyday activities with the baby like talking, singing, reading and playing. So the first contact person, that is the mother, is the most important person, and the immediate family members or the close relatives are again the next most important source to provide early stimulation, and rather exposure to television and mobile prevents early stimulation because there is only one speaking from only one source itself. So the aim of early stimulation is to stimulate the child through normal developmental channels, prevent developmental delay, prevent asymmetries and abnormalities, detect transient tone abnormalities, and minimize persistent tone abnormalities. As per the World Health Organization Early Child Development Nurturing Care Framework, early stimulation is important for responsive caregiving and promoting early learning. And this is achieved via 4 major sensory modalities, which are visual stimulation, auditory stimulation, tactile stimulation, and vestibular kinesthetic stimulation. Next is the process of early risk stratification, which we do from low to high. The recommendation is to risk stratify the NICU graduates, which also involves newborn screening for congenital hypothyroidism, phenylketonuria, and hearing, because all these are almost modifiable. Counseling parents for early stimulation and surveillance in the first 2 years as a part of focusing on F1000D. The next recommendation stresses screening by trained Anganwadi workers or developmental nurse counselors or developmental therapists or PHC doctors at community early intervention centers and block early intervention centers using simple validated Indian screening tools at 4, 8, 12, 18 and 24 months, as has also been mentioned in the video on global developmental delay guidelines. The next or the fifth process in the habilitation is early detection, and this involves holistic assessment of 10 common neurodevelopmental disorders at child developmental centers or district early intervention centers by multidisciplinary team members involving developmental therapists, developmental nurse counselors, physiotherapists, occupational therapists, speech therapists, clinical psychologists, along with developmental pediatrician or simply a pediatrician as the team leader, and confirmation of diagnosis by a developmental pediatrician or developmental neurologist, child psychiatrist using clinical or diagnostic tools at the CDC or DEIC. The screening tools available for developmental delay are the following 11. For epilepsy are the following 2. For autism and ADHD are the following mentioned. For specific disabilities are there mentioned here. For example, for neonatal neurological abnormality, Emil Tyson Neurological Assessment is a very good screening tool. So, the recommendation says that specific learning disability is the most common neurodevelopmental disorder in India after 6 years of age, and special efforts should be made to establish the epidemiology of infants and toddlers who are at risk of specific learning disability wherever measures are available. The last but the most important step is early intervention, which involves providing an individualized care plan. This is referred to as biopsychosocial model, and it involves allied specialists as well. And we must all get ourselves trained in early stimulation and early intervention to prevent impairment progressing into disability and into handicap further on. The recommendation stresses on to providing parent-guided low-intensity multimodal therapies before 3 years of age as a center-based or home-based or community-based rehabilitation services supported by a developmental pediatrician or physiatrist. MKC's Trivandrum Developmental Screening and Intervention Package is an easy early detection tool. Here the developmental pediatrician introduces it to the mother at the center level using simple scientific and specific interventions to address delays or disabilities, and the mother continues to do it at home, and the child is monitored periodically at the center. So the intervention is being provided by the mother at home and continuous monitoring is being done by the Child Developmental Center. Next, the WHO International Classification of Functioning Disability and Health Model is also a useful tool to formulate an individualized intervention care plan. It takes into account not only the physical impairments of the child, but also the child's activities, participation, his environmental facilitators and barriers, and his personal specificities. So this is a list of common intervention packages that may be used for habilitation. And I guess people may take a screenshot of the same. Developmental pediatrician should seek guidance whenever necessary of allied specialists like pediatric neurologist, geneticist, etc. The team leader should keep a record of periodic follow-up assessment and feedback on emerging developmental status, and the same to be shared with parents at regular intervals because they go through a lot of mental trauma. Then there is a need to promote ongoing academic programs in clinical child development, which may be at graduate or postgraduate level or any other certificate program by the non-governmental organizations or the government under Rashtriya Bal Suraksha Karyakram for capacity building of community-based therapies. But there are challenges faced at different levels. Parents feel that the main challenge faced by the parents is a lack of school's preparation for the child's particular developmental needs, especially in terms of the physical environment. Teachers feel challenges in meeting the needs of these children within the context and resources of the classroom. So the habilitation package should include assessment of school's readiness of children and predetermined plans facilitating the smooth transition of children to schools. To recapitulate, there is currently a dire need for nationwide studies for epidemiology of babies with early neurodevelopmental disorders, and a habilitation algorithm has been followed in this consensus statement. First, should be preventive management in conception, pregnancy, and perinatal period, which involves preconception counseling for F1000D, that is first 1000 days of life. Then there should be implementation of best practices in the labor room and NICU to minimize brain injury, which involves organizing systematic training programs in neonatal resuscitation, lactation management, developmental follow-up, and early stimulation. Early stimulation, which shall help in screening for delays and also promoting the neurodevelopment of the baby. This should be followed by very early risk stratification of the NICU graduates, followed by early detection using holistic assessment of 10 neurodevelopmental disorders at CDCs and DEICs, followed by confirmation of the diagnosis, and finally an early intervention involving individualized care plan referred to as the biopsychosocial model, involving all the allied specialists, which includes parent-guided low-intensity multimodal therapies as well as multidisciplinary team management and promoting ongoing academic programs in child development. One must also remember as a specific recommendation that specific learning disability is the most common neurodevelopmental disorder in India found after 6 years of age, and parents should be very cautious, and developmental pediatricians should have eyes and ears open to screen the same. As a new addendum to this video, as you all must have noticed throughout, I have added the word Q wherever I think that the subject matter or the text is important for you from an examination point of view. So I hope it is of use to you. Thank you so very much for a very patient listening and watching, and please do share the video for maximum benefit of all. Thank you. Thanks a lot.